We're really excited to have you here, and we're very excited to have two fantastic panelists, David Katz and Arslan Idrees. Did I get your last name right?
That's
Not
right.
Quite. Okay. We're so excited to have you here, and we're going to start off with some introductions. My name is Maggie Bergeron. I'm a physiotherapist in Toronto, the co-founder of Embodia, and I'm your community director for TechTO Health. We are having these online panel discussions every Thursday at 12 p.m., and we would love to have you join the conversation. And what that means is that throughout the panel discussion today, you can post in the chat. Right now, you could post a hello and just introduce who you are and where you're coming from, which would be fantastic. TechTO Health is really a community of healthcare implementers and healthcare innovators. So we bring together both those who are building innovative solutions for the healthcare industry with those who would be implementing or using them, such as frontline workers. And today's discussion is going to center around adapting business and healthcare during COVID-19. And with that, I'm going to have David introduce himself first, and then I'll pass it over to Arslan.
Thanks, Maggie. David Katz, I'm EVP at Benecaid and head of Honeybee Benefits. And for those who don't know, Benecaid is a health benefits, group benefits provider in Canada. And we partner with insurance companies, health services providers, companies providing services targeting SMB, and we roll it all up into a group benefits offering, and we go to market through advisors. Happy to be here. Fantastic.
And Arslan.
Hi, I'm Arslan Idrees. I lead digital transformation at SC Health. SC Health is our 100-year-old home care company that provides nationally home care services. Part of my role at SC Health is to lead the digital transformation from the vision, strategy, and all the way to execution, working across internal and external stakeholders to enable the 20,000 plus care exchanges that we deliver across homes in Canada. Happy to be here as well.
So we'd also love to know who's there. So if you head over to the poll section, we'd love to know who you are. So would you consider yourself either an innovator, builder, both? Builder, just so you know, should be actually implementer. So innovator, implementer, both, or other. Innovators are those that are building interesting solutions for the healthcare industry. Again, builder should really be implementer, which are the healthcare practitioners, or if you work for a healthcare organization, that would be you, or you might be both. So just let us know in the poll. We'd love to know who's joining our community. So again, as we go through the panel discussion today, please post your questions in the chat, and we will get to them as we go. I'd love to open it up first to discuss what are the changes that you've seen in your business as a result of COVID-19. And David, I'll pass that to you first.
Yeah, sure. I mean, what hasn't changed? I mean, we were just talking about that. There's Benecaid and Honeybee, which is a sort of like the platform brand of Benecaid. We predominantly provide solutions that are blends of self-insurance and insurance and sort of other ancillary products. What I think we've been seeing is something that I think we all see, which is people are at home. People can't have access to healthcare the same way. And particularly in the insurance industry, that has impacted claims. If you can't go to your doctor, you can't go to your physician, you can't go for your physiotherapy, you can't go for rehab, you aren't submitting claims. And so that's been one area where I know most benefits providers and insurance companies have been very active trying to find ways to work with clients in order to sort of optimize their plans and their premiums and help them out at this time, recognizing that they're not using all of their products. But in other ways, we've seen quite a heavy amount of claims, prescription drugs, and in other areas as well. We were an early proponent of using virtual care, and Honeybee actually going back to 2017, we kicked off with Akira as part of all of our group plans. And so, we're seeing a lot of uptake on those products and a lot of usage. And so it's really, I'd say that's one area, which is more the claims side of the business and how they're using the product. The other area that I think it's had a big impact is just working with our clients to find ways to make changes to plan designs and things that reflect the new economic reality. And so, particularly on the Honeybee platform, it was designed to address different problems that an employer might have. Up to earlier this year, up to the start of the year, a lot of companies were using Honeybee in order to attract and retain talent. It was a real talent war. And so using non-traditional benefits and things like that in order to really promote the culture of the company, provide solutions and benefits that are not things that you'd find in a traditional plan, personalization of benefits, that was really high on employers' lists. Today, I think it's different. It's cost containment. It's a shift to essential coverages. It's, perhaps we'll start seeing a bigger shift towards defined contribution, things like adoption of health spending accounts. And, because it's hard to predict how employees need their benefits today. So flexibility is still important, but core coverages, I think, are taking the stage right now.
Fantastic.
So we're busy.
Yes, you're busy like many. And
yeah.
Arslan, what's going on with you and SE Health?
Yeah, Aspen, you can imagine we got 9,000 people that are going across the country and people home in vast majority of the time. We do have transition programs and hospital partnerships and clinics, but a vast majority of our services are done in home care setting itself, right? And with the practicing social distancing piece, you can imagine that we have to provide the care, right? If your personal support worker is showing up in your house to bathe you or provide some personal support, there is touch involved in it, right? And the IPAC best practices of social distance, like how to provide care, precaution that needed, because this virus is very new, the information keeps changing on a daily basis. So you have to effectively communicate that to your staff and then continue to keep them up to date is probably one of the biggest challenges for us. And on the same side, while the care model has to alter slightly, we still have to make sure that the people that need the care in the most critical manner, let's call it the ERL codes, which are more high-risk patients, we have to do them without any fail, right? And the last aspect of it is, can we provide the care in a new manner, as David was talking about the virtual, right? Which probably, I think 3 months ago, some of us would have been fighting, arguing, why ministry cannot make it happen. And now suddenly that's, there's conversations that I've been sometimes part of. Can we just use WhatsApp to make a call? So there is certainly that flexibility that comes in. But if I go back to the communication part, we as an organization now have a weekly organization virtual town hall every week. And you can imagine that every week we are getting together at 7 p.m. on every Tuesday, which is an open forum for the whole organization to come together. Then there are direct communication channels I call it our intranet, which is our internal SharePoint-based site. We are starting to leverage that. We have Microsoft Teams for direct connections. All those tools were in place. I call them, these were capabilities that were not properly utilized because the need was not that much, or even the need was there, but there was a lot more protocols, let's put it that way. So we relied on a lot of different channels and it delayed the touch point with vendors. Now our first and the foremost point is, because it's changing every day, we have to get in front of them in near real time. So we're using mechanisms that allows them to know all the information, but the critical information in a very streamlined manner. For virtual care, we have now started implementing robocalls, which is basically automatic calls going out to our patients and actually doing screening. As you can understand that in order to do the safety first model, which was always ingrained in the way we provide care, but it wasn't the left, right, and center of what we think about when we provide care, especially staff safety. So now we start with a safe staff. So every morning, every single staff has to do their own screener as per the government and our own guidelines. And then you have to do screener for every single patient that you're going to see. You can already see that actually, but the result of that screener can actually alternate and dictate how you will provide care and what can and cannot be provided. So even literally in the morning, if you have symptoms and you turn positive from a screener perspective, the whole protocol change. And you can imagine that as the numbers are growing for COVID-19, symptoms are growing, and the community spread is there, it's becoming very dynamic. So which means that the data becomes very important, critical decision-making becomes important. And some of our tools and our processes that we have been put in place over the last years have been started to get tested. But at the end of the day, we're moving more towards robocalls. So can we do that screening ahead of the time automatically, so there's less filters for humans to do, and also giving patients an upfront choice if they are non-critical, lower risk, if they are okay for virtual care. So it's a mix of a lot of that. And then on top of it, I think the last part I would add is the personal equipment, right? PPE and the shortage that exists with it. Historically, obviously, home care has not been a big user of PPE equipment, so which means we don't hold a big supply in general, and usage for us is very limited to certain kind of diseases only. So now, literally, we have to alter that whole, not just acquiring the PPE, but you can imagine, right? You got 8,000 plus nurses and PSW across the country. How do you distribute the right equipment to them based on who they're seeing? And it's a logistic, literally nightmare for us as well. So we had to quickly create optimized logistic plan, and then continuously optimize it, because the protocols changed for us from 1 mask to 2 masks to now, as of this Tuesday, last Tuesday, we now have to give you covered shoes in case you are COVID-19 positive. So the shoes also needed to be covered as part of the protocol. So which means from acquiring them to distributing at our distribution centers and to the nurse, and then keeping track of it is all becoming what I call the daily routine of us.
Yeah, absolutely. And so many changes that have happened in the last 6 weeks or so as a result of the pandemic. And really what we've seen is that the adoption of health technology has been accelerated by about 50 years. Maybe that's an exaggeration, but by many years. So there are changes that have been made, like you mentioned, about maybe short-term solutions. But what are some of the long-term solutions? What are the things that are have come around now, that are likely going to continue to be used, whether it's a protocol or technology or new program or business model?
I'll answer it in 2 ways, right? So there's one, changes in technology that I call it operational excellence, right? As an organization, most implementing that honestly will become the part of how we're going to work from here on. And one is the external factor. The internal one, frankly, while our focus for me has shifted for my own team, and our focus is all about employee and patient safety, is the foremost thing that we almost think about. So we have created under our organization command center for COVID-19. For the digital team, we have 2 priority focus areas, which is patient symptoms tracking and tracing, and same goes for employee in every aspect that we do. So we have the mantra that we have, go live, which is shoot, literally, and then aim, and then think about it. But the idea is that as soon as you go live, we start actually talking about, now that we're live, which was actually literally sometime we're going live with things in like 24 hours or 48 hours, which is a miracle. I'll frankly tell you, for our organization, we'll spend that many times discussing even for months sometimes, right, on what we want to do. But now we're going live with things in days. But the idea for us is that we come together as soon as we go live, think about what's the longevity of this. We don't need to do that right now, but can we do some things, create a parking lot for things we want to do, so that these things stick. At least for our idea is that if we can actually keep even 50% of this, we as an organization will be a lot bolder in the new world when this all settles down. Same goes slightly, mindset is slightly different for external. The reality is because when you change for external, those changes are becoming much more inherently permanent, let's put it that way. So the robocalls, the virtual care piece, absolutely is going to become the way we're going to work. In home care setting, historically, as you guys are aware, as a kind of user, and even some friends and family, if you guys came across it, it has been run as a very traditional transactional model, and that's just the way the government funding was. Even though the virtual care funding that has been changed is still very transactional, but I think it's very encouraging that the change happened, and now it is almost like step number one toward value-driven care, where hopefully the decision will be left, like the decision for virtual care versus in-person visit has been left with the care provider. I think the value, it is step number one towards the value-driven model, where hopefully we can also dictate, is there even a need for a visit? And all those things that some of us have been advocating for years, this step number one toward virtual care and its offering in a broader setting. And from a tech perspective, frankly, we're using virtual care right now. We're using Microsoft Teams because that was the fastest way for us to start utilizing. But at the same time, it's these specialized technologies that we've started to explore in parallel. For example, we're now working part of a national coalition for digital wound care, where those technologies and those things have started to move forward, and those will stick around. Right, in the weeks to come, we will be implementing, and they will stick around for us.
It's interesting. I think those are great points. I think when you look at what's happening now, there's a real convergence between public and private. I mentioned earlier virtual care, that we were, early adopters, but there's a lot out there already. There was already a lot of traction in the space, Akira, Maple, Embodia, and a lot of others, Dialogue, MindBeacon, Inkblot, on and on. And, now we're seeing it front and center. And the question, when you look at accessibility, and if you take a step back and you look at what's happening in the space, there's a lot of blocking and tackling that's happening right now. And that is almost like, how do we mobilize very quickly to bring us in terms of facilities, PPE, in terms access, a whole bunch of issues. And it's really pointed out a lot of the weaknesses in our system in terms of scale and capacity. But then there's this whole other category of accessibility, and that's sort of where virtual care is. And it had traction, but now we're seeing the public sector step in and saying, well, this has to last. It's, it's not just something that could be provided in group insurance plans or group plans. There's millions and millions of Canadians who don't have access to employee benefits where they might get this service. How do we bring it to them? And I think that will last. Makes you wonder whether the market is sort of big enough. There's a lot of players in the space right now, so I'm not entirely sure what the market size really is. So we might see some consolidation there. We might see more services getting layered on to virtual care. We've already seen it in terms of starting with virtual care and then moving into a clinic by way of referral. So I think there's a lot there that will continue. But we're really in this phase now where we're moving towards a model where we have to really focus on building. There's a lot we have to build in our system, and there's a lot we have to then invest for the future. So, accessibility, and we talk about virtual care, as you alluded to earlier, there's so much that's still happening within accessibility that is what I describe as blocking and tackling. You can look at, things like the initiative started by Dr. Summers working with Bell Mobility to get phones in the hands of people who are homeless and people who suffer from mental illness in order to contact them after they leave the hospital to let them know their test results or to bring them back or follow on care. And now that seems to have spiraled. TELUS is now, giving away, thousands and thousands of phones to patients for connectivity. So everyone is all in on this right now. It'll be really interesting to see where the government picks up, how this impacts things like national pharmacare. Is the government going to widespread adopt virtual care? Is that going to reduce costs for employers who used to have to pay for this for their employees? You can't separate the discussion of technology and where we're going with, where is the pocket? Who's paying for all this? And so I think we're going to see a little bit of a shift from private sector to public sector for sure, and it's already started. And then there's the whole other question about, how are we investing in the future? How are we using technology? How are we using AI? How are we investing in startups? How are we keeping them employed so they can continue to find breakthrough technologies? And so I think a whole revolution has started right now. I don't know who the winners and losers are going to be, but I do know that there's extreme attention on the sector right now. And it'll be very interesting also to see, in my industry where I spend a fair bit of time on the health benefits side, we have a whole other problem happening there. Insurance companies make money by investing money, by investing deposits, and we're in a zero interest environment right now. And so, and the insurance companies are also stepping up, and we've been working with a lot of them to try to find ways to give credits to companies for benefits that they haven't been able to use. All this comes out of a pocket. And so how does this impact premiums and rates going forward, for companies that want to provide benefits to their employees, and all of a sudden you have premium increases because the insurance companies need to be able to generate a return. And so, again, do we move more to defined contribution and things that we've seen in the pension space in the past? Is there a combination of the two, which is, probably where I think it's going to end up? And then how does that put more money back into the pockets of small businesses so they can continue to keep people employed, which also impacts premiums? So it's a real vicious circle. And I think really keeping an eye on where the money's coming from is very important.
Absolutely. Thanks for sharing. Hi, Jeff.
Hi. Sorry I'm late.
That's okay. We're happy to have you here.
Awesome.
It's like a surprise panelist.
Exactly.
So why don't you spend just a couple minutes introducing who you are and the work that you do?
Sure. Thanks. So again, sorry for being late. I guess I have a few different hats. So I am a physician. I was seeing some patients virtually this morning, and so clinically kind of adapting to the new world. I am also an entrepreneur, so I've started a company that focuses on how do we deliver better medical nutrition therapy, or almost prescribing meals that are personalized and diets. And so we've seen a large expansion of that over the past few months. And I think one of the concerns that's happened with COVID is people do not go to the hospital unless they really have to. And, having been working in EMERGE during this COVID crisis as well, the number of internal medicine consultations and admissions that are non-COVID related has plummeted. And the concerning part is people with, myocardial infarctions, MI, heart failure are staying at home longer, and medical teams have to figure out how to give that care to them at the home. And so that's where we've been trying to give our solution, is to help facilitate new, more enhanced ways to deliver home care related to chronic disease management and prevention. And then I guess the third hat that I've been kind of playing relevant to this space was I'm also director of medical affairs at the Ontario Health branch for OTN. And so just to give a comment, I think I've been working with OTN for about 4 years on various aspects of Ontario Telemedicine Network of how to explore virtual care. And, in the 2 weeks at the end of March or the beginning of April, we saw more growth and expansion than in the 4 years prior to that. And I think it's just going to the fact that we are in unique times. And I think it's will be very interesting what happens from here.
Speaks to some of the points that we had been discussing around the changes that are occurring now, how change has been accelerated so quickly because of the pandemic, and then what's going to occur after. What is the post-COVID world going to look like? And you make a good point there about fewer people going to hospitals, going to emerge and making those visits. So therefore, there could be many secondary impacts that some of us may be thinking about, as you clearly are, and I'm sure David and Arslan, you've been thinking about it as well. But what are some of those secondary impacts, and what are the things that we should be asking ourselves right now or implementing to kind of mitigate the risk?
Yeah, it's a great question. I think there's probably going to be a lot of secondary impacts. I think one is, like I said, you ask a patient to kind of go in and get even a test done that we think is important, and there's caution around that now, right? So we really have no idea of how long this is going to last and what the implications are for seeing, in some cases, 25, 30% drops in the number of people going to see physicians and get testing. So, I mean, what is that going to do is I think it's going to have some negative consequence, but we really have no idea of how big that is going to be yet. I think as other people have identified, there's also significant concerns around mental health and the link between mental health and chronic disease. And, being isolated, that's only likely going to increase, which I think is going to complicate things further. There's other concerns brought up around research funding. So I think rightly tons of money and research trials have poured into COVID-related work, virtual care, but at the expense of perhaps other types of work, other kind of, cancer treatments, other drug treatments. So some of those other areas are put on hold. And again, until we know the long-term impact, it's hard to say what it's going to look like. But I think diverting a lot of energy solely into this, I think obviously it has to be done. This is a declared pandemic, but the secondary consequences, I think, still are unclear and could be quite significant. And just from a medical side, and then you think about economic and other aspects and how those play into the social determinants of health. So yeah, I think more than ever, we need to be thinking about all the different complications that can happen. And when we are developing our tools and technologies, thinking about all the other ways that we can help. And maybe a lot of the stuff that we're learning by advancing virtual care for COVID can also help all these other problems. We just have to kind of realize that they can apply to multiple areas and hopefully can be holistic about it.
Arslan, do you want to jump in there and provide your thoughts?
Yeah. No, absolutely. I think for us, one of the things that it's like I said, like many of these things are like learning on the go and figuring it out and things in real time. One of the things that I can share is that in home care setting, folks, individuals themselves are making sometimes elective decision that I don't want to continue the service. Doesn't mean that they are saying that discontinue it and discharge me, but put it on hold. And sometimes they're making the decision without really knowing the medical reasons or impact that can have on them. And it was done, most of that is done based on the fear, right? Of can somebody walk into my house and just give it to me? And as we were going through the mapping, even yesterday, frankly, one of the things we figured out is that, so from a referral point of view, there's a hazard code that was put this person on hold. What we're now trying to do is map it back to what we had a risk coding, which is from 1 to 5. And if it's a higher risk patient, and we have not seen them for the last 48 hours or 72 hours, and we were supposed to see them every 2 days, we need to actually go back to them, proactively, and at least ping them and say, okay, what has happened? Like, do you want us to come in? And that's where the robocall can be made. Because there are consequences of not having that visit. That will go a lot more. So if you're, for example, wound care patient and we have to change your bandage, you could put on us on pause, but that will have complication for you, right? And I think that's the challenge between those non-critical folks, because sometimes tagging people with just CRL code is one aspect of it, because we don't have the entirety of all the information coming with the patient. And that's probably one of the biggest challenges for our healthcare is, right? So we have the information that we just know at that moment and point, and we have to make the best decision based on it. But the consequences of perhaps not having that visit because the patient themselves selected to put it on hold, there was some other things that were going on in their life that we are not aware of. And they might be just a simple wound patient, but like Jeff was talking about, they might have a mental history and other issues related to those problems that can be inflated. And I think we as healthcare providers have to start collaboration a lot better. And there's a lot of conversations going on. It's just challenging time, and I think that impact is becoming now it's just firefighting. But as the things are settling for us, we are trying to figure out, okay, the first wave is out. We can actually provide the care the best we can. Now, question is, can we look at some of these consequences which will impact us 3-6 months down the road?
Yeah, it's interesting. I can tie that actually, Maggie, to one of the questions that I see here.
Perfect.
Where Maury's asking about whether insurance companies will continue to invest, or if we see them investing in tech companies that decrease serious health issues or improve outcomes. I was listening to the CEO of Kaiser Permanente in the US speaking the other day about how in their network, about 50% of their members use virtual care already. And that was an investment that they made. However, their biggest concern is not, are we going to continue to invest in things that help health outcomes right now, but they're concerned with the number of acute cases in their network that will become exacerbated and become severe health issues because people aren't seeking care right now, even with virtual care. And so how that secondary impact, I think, is becoming more immediate and more of a priority for a lot of insurance companies. That and the run on claims that's going to happen when people finally come out of their homes and start going to the doctors, how they're going to deal with that. How does that impact capacity in our healthcare system once again? And is it again a vicious cycle, because then people can't access care and their acute problems become chronic again? And so I think that's where the mindset is right now. But I don't think we've seen investment in Canada as well in technology companies. We've seen Chris points out some in the comments there, but we've also seen more Manulife's investment in Vitality. I don't know if it was an actual investment, but there's commitment to Vitality and bringing it to Canada, and certainly an investment in terms of dollars spent, which there's complete alignment between an insurance, someone who has insurance, life insurance, particularly living longer, and the insurance company wanting them to live longer so that they can collect premiums for longer. So there's complete alignment there. So I think there will be continued investment in by insurance companies and technologies that help people live longer, healthier, better lives. Green Shield made an investment recently in MindBeacon on the mental health side. So there are investments happening. I just wonder whether the focus will be more on immediacy right now and access to care.
Yeah, fantastic. And there's a few other questions here popping up about virtual care and telehealth. So let's discuss those. One of them is around virtual care being the Wild West right now, and people can access it through insurance, but how is the data being consolidated? And there was also a question about consent. So collecting consent for virtual care, and then also what is happening with the data. Is there a plan?
I can go first, Maggie. On our side, the consent is very important. When we are having a contact with the patient, while there are generally a blanket consent forms that typically get signed, but in this case, for virtual care specifically, the patient can decline virtual care, which means we will go to the normal form of care. Now, there is an impact. If you are a low-risk patient, then the care schedule can slightly alter, but the patient actually can request an in-person visit from our point of view. What we are seeing is that there are a lot more patients who are actually much more comfortable with virtual care conversation. I think the second part of one of the question that I think Maury had asked, not everything can be provided by virtual care. Absolutely. You can't bathe someone. As simple as that, right? You can't bathe somebody virtually. You can't tell somebody that go into the shower and turn the water hose on and just take a shower and come out. Absolutely. But what virtual care can do, even in that scenario that's so, call it touch heavy, that we can empower a caregiver of friends and family and arrange and work with them and coach them on how to enable that interaction. And maybe if that's possible, maybe that's not possible for everybody, but that is possible for certain people, right? And that is the kind of analysis and reviews that we are doing on a daily basis to make a call, what is possible, what is not possible in virtual care, and upfront making that decision. And if it is not classified as something that we can deliver virtually, then there's no point on doing the virtual interaction, at least from our point of view. And then we will continue to deliver the care the way it was supposed to be delivered.
Yeah, I think that's interesting. That on the data side of that question, where I think the discussion will be headed very shortly is, these are all sort of disparate systems. We don't have medical data liquidity in Canada. There's so many different systems where this data resides. We're seeing investments in companies to try to digitize records. Even recently, even during this crisis, there was funding for a company called Pocket Health that essentially is trying to eliminate CD-ROMs of medical imaging and digitize those records so that there's accessibility for doctors and for patients. There's a lot happening in the space, but at one point there was a discussion about a unified health record in Canada and how do we get essentially our own medical wallet of our own information and all of it digital and easy to share, and where you have private sector virtual care collecting data now, where does that go? I think this discussion is going to come to a head pretty soon, and I think it's going to come into play around a national network of virtual care. Virtual pharmacies are now popping up. So how does that work? Shoppers Drug Mart is investing in a whole bunch of different employer solutions as well as virtual solutions. So there's a lot happening here, and we still don't have convergence in terms of platforms and the ability for the data to get passed from platform to platform. And I think the discussion starts with privacy, and it starts with a unified health record and a common investment in platforms that we can use as a country, and that people can, with the proper access and credentials and consents, can tap into that network and be able to provide services into it, as well as allow consumers to take their data out of it easily. It's really, I don't want to belittle the discussion, but it's really no different than the discussion we're having with open banking in Canada. We don't have the level of liquidity that we need in terms of data. And with all of the money that is now going to rush into the sector, a lot of that is going to be, I'm not going to say wasted, but there's going to be a heck of a lot of waste in that investment, because we're going to continue to try to fund multiple platforms without convergence. And I think that's a problem.
Yeah, I would agree with both Arslan and David, and this is the big challenge. At the end of the day, I think you have to think about the model of care you're trying to solve, and virtual is a means to deliver that. But a model done virtually is actually more of a waste and fragmented and may not have the security. And so I think a rush to doing all these systems that may not fit together and data that's not connected is not going to really, I think, be sustainable or deliver value in the end. And so I think that's going to be one of the key challenges that we face going forward. I think, consent and data is something that is still not clearly defined when you get to the private sector. There's still ability for various degrees of sharing and access and control of that data, which is not always transparent. And I think that's going to be an ongoing risk going forward. And then also getting that data back to the right people, the primary care provider, your psychiatrist, if that's what you need, whoever needs to do that is important. And so it is going to be an ongoing challenge. I think with InterAnalytics, our platform, we've done a lot to we've always been virtual, and we've kept the same consent process, and we've tried to fit into workflow as best we can. And even that is so hard because every clinic has a different process to it. They have a different EMR. And so you can see how it's a big challenge, and it's a problem that, is not necessarily solvable by one group. And, this idea of that unified record, decades it's been being talked about. Hopefully this will be something that pushes a little more direction there, but it is a very tough problem with a lot of different stakeholders.
Maggie, I think maybe one point I would just share that tells you the complexity of the data interoperability, right? And while systems and everything, and obviously all of us want to do that. I think everybody I have talked to in the last year and a half, everybody wants to do this. This is like the number one thing on the agenda. There's so many ministry forums that I've participated in that I've even lost track of it. If I take a step back and let's talk about COVID-19, and Jeff probably is more qualified than I am. There cannot be that many statuses of a patient, right? Either you're positive, you're probable, you're asymptomatic, or you don't have symptoms, or you came in contact. Just making, like there could be 5 or 6, right? If I tell you that across Ontario, specifically only speaking about Ontario at this point, there are 21 different classifications that I'm receiving for the patient on average. And then each of that classification then have its own categories. And then the comments in the description tells what the status of that patient is. How can we do interoperability? Because across these pockets, across Ontario, different divisions, different government bodies, let's just say, are sharing information differently for the patients, all right? And for me to produce how many patients are positive, probable, screen positive, or all the couple of other categories, it's a mess, right? And this one is simple. All it needed to be done is create 6 categories, guys. It's university. There's a definition that was published by Ministry of Ontario, but practically how many times it's getting used, right, on those classification. It's a good testament for us to also see that interoperability and something, leave it aside, we can't even agree on definition.
Yeah, absolutely. There's lots of comments going off in the chat there if you want to add any thoughts. We are going to just wrap up with some final closing thoughts from each of the panelists, as well as where people can find you if they're interested in connecting with you. So what I'll ask, we'll go around and provide some closing thoughts in about a tweetable, so about 280 characters or so, as well as where people can find you, could be your website or however else you like to connect, and then put that information into the chat as well, just where they can connect with you into the chat so people can find you. And I'll start with you, David.
Okay, so some final thoughts are, I talked about, so infrastructure, accessibility, and innovation are all happening at the same time right now. And Blueprint isn't happening. And so we need to find a way to start triaging the most important of those priorities for Canada. And we need to start building, but we need proper blueprints to start building in a way that makes it sustainable for us. And I'm going to leave it at that. And I'll say that anyone who wants to reach me can get me at dkatz@benecaid.com. Best way to get me, and happy to chat with anyone about this. Thank you.
Thanks so much, David. And just drop your email address there in the chat. Arslan, I'll hand it over to you.
Awesome. Yeah, no. For me, best way is the LinkedIn. I just put in, you can search me on LinkedIn. I'll probably add the link as well. I think for me, maybe while there's many things, if I take a step back, I think the mantra as an organization, as healthcare providers, and as a country, maybe what we need to do is a quote that coming to my mind, which is the CEO of our CEO, Shirley Sharkey, said it beautifully in the last one of the fireside chats for her, that we collectively have to do this, right? And it doesn't matter who gets it right, as long as we get it right. And which means that different organizations, competing organizations, have to come together and have to solve this puzzle together, because that's the only way we'll get out of this with less mess than we got in. Otherwise, coming out of it, we'll have more mess that we're in. Thanks.
Perfect. Thank you. And Jeff.
So I think I would say that, these are extremely unprecedented times, but it's worth reflecting on what we were forced to do that worked well. And we always talk about returning to normal, but some of the things that we've had to do differently here are important to be maybe the new normal. And so, let's try to figure out what we can learn and what we can put forward to make things better. And that's, think holistically. I think just to that point that there's a lot of mental health, there's a lot of broader issues, there's diet, there's sleep, there's a huge component that needs to be thought about. And sometimes we get laser focused on one particular problem like the COVID itself. So just think holistically and try to maybe think about one or two things that you actually might want to keep doing that you were forced to do because of this event to make you better, leaner, faster, more efficient as a company, as a person. Yeah.
Fantastic. And I saw that you put your information in the chat there, which is great.
Yeah, I got my email, LinkedIn,
Perfect.
if anyone wants to connect. Thanks.
So with these events, we have the opportunity to do networking as well, which means that you can connect with others and speak with them directly. So you'll be on video chat with one other person. And we're going to do that in a couple of minutes. So just stick around for networking. And the networking, I believe, will be open until 1:30, but I'll have Leah just post in the chat to confirm that. I just want to say thank you to all of our panelists. I know you're all extremely busy, and I really appreciate you taking an hour out of your day to join us and to share your thoughts and experiences, as well as where you think the healthcare system is going. We run these events every week. We have a different panel each week, a different topic, although most of them are centered around COVID-19 and the impact it's having at the moment on the healthcare system, as well as health tech companies. So thank you so much. We're going to do this again next week at 12 p.m. Eastern. And Leah also just dropped into the chat the link, so you can join us. And next week, we will be speaking about investing. David, you had touched on this a little bit, investing during this time, that there are companies that are raising, and some have done it successfully. It is definitely a hot topic right now in health tech because it is a challenging time for investment, but maybe an opportune time as well, as we all spoke about. So thank you so much for joining us. And if you are sticking around for networking, then all you need to do is head over and click the networking button. You will be connected to somebody else that's on this call. You will have 3 minutes to chat with them. And then at the end, if you want to exchange contact information, you'll be given an option. There's a button at the bottom where you can exchange contact information. And after 3 minutes, then you're moved on to the next person. So it's a pretty great way to do some networking, to meet some other people on here. And we look forward to seeing you next week. I hope everybody has a great rest of their week.